Thanks very much, Imogen, and it's great to be back again for a second year. So as well as treating melanoma, I'm also a neuro-oncologist, and so I'm talking to you today about brain metastases in melanoma, and wearing both of those hats, really. So what I'm going to talk to you today about is largely stereotactic radiosurgery in combination with other treatments. And I'm going to show you explain a little bit about what that is and how that treatment works, and give you a few examples of patients that we've treated in the past. Some of those will be melanoma patients, but I'll also be using some other different tumour sites as well. So how big is brain metastases as a problem in melanoma? And it's clearly a significant issue. Up to 25% of patients diagnosed with stage 4 disease will have brain metastases. We know that 70 to 80% of patients at post-mortem will have evidence of brain metastases. And it has been traditionally associated with a poor prognosis, so typically in the 4 to 5 month range. And clearly we need to do significantly better than that. And I think we can now with new treatments that are available. So when we're dealing with brain metastases, what are our goals of treatment? Well, clearly we want to prolong overall survival. That's absolutely critical. But the other things that we need to think about are preserving or improving neurological function. We need to reduce or eliminate the use of steroids. So steroids are very common treatment in people with brain metastases to try and reduce the swelling and edema in the brain. But they come with their own problems, and they certainly have significant side effects. We want to minimize the side effects of treatment, and critically, we want to allow the continuation of treatment of any extracranial disease that may be present. So what do we know about brain metastases? Well, we know that tumours are moderately well circumscribed. So they are very different to primary brain tumours, which are very diffuse and spread out into the surrounding brain parenchyma. So this allows us to think about very focal treatments. So resection has an important role and remains important for particularly large tumours. We also know that survival is actually related to the control of extracranial disease rather than intracranial disease. And it's certainly true that whilst the average survival is not anywhere near where we'd like it to be, prolonged survival is absolutely possible. So what are our options for treatment? And really we can look at this as there's two sets of treatment available. Systemic therapy, which we've heard a lot about today. And then there's also the focal therapies. So stereotactic radiosurgery, surgery, as I've said, open surgery for large brain metastases. And then there's things like whole brain radiotherapy. I've put a question mark by that. I mean, whole brain radiotherapy, I think increasingly the evidence that we're seeing, a number of studies which have looked at stereotactic radiosurgery with or without whole brain radiotherapy, and I think it's very clear that what whole brain radiotherapy adds is better control in the brain, but without any benefit in terms of overall survival, and it's considerably more toxic in terms of cognitive impairment. So I think, personally, I'm not an advocate of whole brain radiotherapy. I give it very, very rarely these days. So this table really sums up systemic therapy, and this is the only slide I've got on systemic therapy because we've heard a lot about this today. And on the right-hand side, we can see response rates and 1 year overall survival for patients with no active brain metastases. And on the left-hand side, we can see the same data for patients with active brain metastases. And what's really striking, I think, is that the patients on the right-hand side, a lot of this we've heard this morning, Checkmate 067 data, invariably these trials do not include patients with brain metastases. So the figures are absolutely fantastic, but it's excluding people with brain metastases. And if we look on the left-hand side, and you can see the numbers under the different drugs or drug combinations, and these are the numbers that are on very small phase 2 trials looking at patients with brain metastases. Last week at ASCO, we've had data for the combination of dabrafenib and trametinib, and also ipilimumab and nivolumab. The figures look better in terms of response rate, but I think it's important to realise that these patients were from cohorts with very limited brain disease and no symptoms at all. So asymptomatic disease. And that's probably not reflective of the patients that we see in practice. So in general, my sort of take on this is what I would expect is that response rates are probably half what we would see in extracranial disease, and they probably are prolonged for about half the time. So things like gebrafenib, for instance, we'd expect a 6-month progression-free survival for extracranial disease, and it's probably more like 3 or 4 months in brain disease. So patients do respond, but not as often and not as prolonged. So it's important to think about what else can we add to try and consolidate treatment. And clearly the brain is a sanctuary site, and tumours, there is this blood-brain barrier, and that is preventing drugs getting into the brain as effectively as it's getting around the rest of the body. Now we can argue whether that blood-brain barrier is disrupted, which clearly it is, to a certain extent, to allow these drugs in. We can argue about what kind of level of T-cell circulation we're getting in the brain, and again, there's clearly some immune response there, but it's just not as good, it's not as effective as outside the brain. So what can we add? Well, I'm going to talk a little bit about stereotactic radiosurgery now. This is the definition of it, and what we're trying to do with radiosurgery is give a very precise and accurate, very high dose of radiation treatment to the target, in this case, in the brain. So typically, it's performed as a single session. Anything more than 5 sessions would be considered radiotherapy rather than radiosurgery. This is a patient in a rigid fixed frame. So this is what's called the Lexel frame, and this is a typical immobilization device that would be used for CyberKnife. We can also use a mask, and we might use a mask or frame depending on clinical scenario. So how can you give radiosurgery? So stereotactic radiosurgery is not platform dependent, so there are a number of ways of giving it. So this is a linear accelerator, true beam. So this is a typical external beam radiotherapy machine which will be available in every radiotherapy department in the country. So the benefits of a linear accelerator for a department is the treatment is quick, you can use it for conventional treatment, and you can treat any part of the body. The disadvantages, however, it is not as conformal, so we can't get as tight a plan around the tumour, and planning times can be quite long, and you can't treat very small lesions, but you're relying on those collimators right at the top, which will slide in and out, and that's really focusing your beam, and they can only go so small. So if you're dealing with something that's less than a centimetre, a few millimetres in diameter, it becomes much more difficult to treat and get down to that small size. There's also an alternative, CyberKnife. There's very few of these in the country, one in Birmingham, as you heard earlier. The advantages of it, you can treat all of the body, not requiring a fixed frame. It's a mask-based system, and this is essentially a linear accelerator mounted on a robotic arm, so like one of those car-making things. The disadvantage is that it's very slow to plan and treat, it's very expensive, and it does require a very large bunker, so there's a lot of shielding that needs to go into the room that the machine is based in. This is CyberKnife. This is the Icon, which is the latest iteration of the CyberKnife. Now, traditionally, CyberKnife has always used a fixed frame, but with this model, you can use a fixed frame or you can use a mask, and we can monitor patients' movement if they're in a mask. So what are the advantages? You get excellent conformity of dose to the lesion, and I think it's second to none. I don't think anything will do it better than a CyberKnife. You have a very steep drop-off of dose outside the tumour. So you go from a very high dose to a very low dose very quickly over a very short distance, just a couple of millimetres or so. It's quick to plan. You can treat lots of tumours, and I think you'd be very limited with a lot of these. You'd be very limited in terms of how many you can treat on a linear accelerator. You can give stereotactic radiation now, so the use of the mask allows us to fractionate treatment. I'll talk a little bit about that later. Main disadvantage of it is really that it's a very dedicated machine for treating the head. So the configuration of the machine, you're not going to be able to get any other part of the body in. So it is a dedicated tool, and obviously it's very expensive Now, what does a gamma knife look like? So if you take away all the outer casing, this is what it looks like inside. So it's just basically a big lump of steel. And within that, there are 192 cobalt sources, so radioactive cobalt, which are on these sector drives at the back, and this piston will push them up and down or draw them back. And the holes that are in there are the collimators, and they're the through which the beam will exit and head towards the head. So when we're planning treatment, we've got a number of shot sizes. So this is a 4mm, which is the smallest size, and if you just put that in, you've got a nice round 4mm circle. You can use an 8mm and a 16mm, and you can use a combination of these things. So you can mix those up. So if you, that little ring there, these 8 sectors around there, you can put 4s, you can put blocks in, you can put 8, 16, and you can shape the beam. And when we're making a plan up here, so we're treating this tumour here, we're putting in a number of different shots to sort of, it's almost like painting by numbers really, and you're just filling in these shots to cover the tumour, which is marked in yellow. So when you see a radiosurgery plan, it's going to look something like this. So we're giving 22 gray, which is a unit of dose, essentially. So that's a very high dose. And if you're giving that in one treatment, that 22 gray is to the yellow line, which is the edge of the tumour. So that means inside the tumour, it's going to be more like 44 gray or beyond. And giving that in one treatment is equivalent, biologically equivalent, to way over 100 gray. So we often think of melanoma as a radio-resistant disease, which it certainly is in terms of conventional fractionation, where we might be giving 2 gray per day over a number of weeks or days. When we're giving this in one go, it's much more effective. Okay, so I think those issues with radio resistance are less of a concern. And the plan then shows that we've got falling dose, so it's a bit like isodoses on a weather, isobars on a weather map, where we're seeing different changes of dose as we move away from the tumour. So very quickly, you know, within a few millimetres, we're down to fairly negligible doses. And to put that into context, that's the same tumour, and you can see in the brain itself, there's really very little dose to the rest of the brain. So that's why it's a good option for treating these lesions. So this is a slide of patients we treated over a 2.5-year period in Bristol, and it's just showing the different diagnoses. So the green section, third one round on that pie chart, is melanoma. So just showing that it's about 25% or so of our patients that we treat with metastatic disease have melanoma, and that's probably a little bit higher than the national average, probably largely because of the other urology, because I treat melanoma as well. I've only got 2 minutes to go. Okay. So we have clearly defined selection criteria. So this is the NHS is telling us that we should treat patients who we expect to live for a minimum of 6 months. We expect those patients to have a good performance status, 0 to 2, and they should have no or controlled metastatic disease. And lesions must be equal to or less than 20 cc's in total volume. So in terms of the no or controlled disease, I would probably argue that controllable disease is probably more important. So we've got a lot of patients who will be referred, who've had maybe chemotherapy for lung cancer, got decent control extracranially, but the intracranial disease has progressed. And as a consequence of that, then they get referred for gamma knife, and we're sort of looking back and thinking, well, now this thing's 3 centimetres, and actually it was 7 millimetres initially, and it would have been better if we'd have treated early. So I think as long as there is treatment options systemically, it's reasonable to treat with radiosurgery, and we'd rather treat lesions early, because if you treat them when they're small, patients will tolerate that treatment much better, and it's more effective. If you treat larger lesions, you're going to get side effects. So in terms of the 20 cc volume, that's really related to the risk of side effects. So we know that when you go beyond 20 cc's in terms of volume, that equates to a tumour of about 3.7 centimetres in diameter. If you go beyond that, then you start to get significant toxicity and side effects due to swelling and damage to brain tissue. That used to say 3 to 4 metastases, but that's changed now. And in terms of number, I don't think you'd be really restricted, and it really comes down to case selection. So just to give you an example of a patient we treated, so this gentleman presents with left leg weakness in April 2015. He had a 3 centimetre right frontal metastasis resected by the neurosurgeons. No tissue at that point. Comes back as melanoma. We do BRAF testing, it's BRAF positive, and there's no evidence of any primary at all, so he's just got this solitary metastasis. Came to see us in July 15. At the time, we were working him up for entry into the Checkmate 238 study, which was the adjuvant study, which I think was mentioned this morning, ipilimumab versus nivolumab. But when we restaged him as part of the workup for that trial, MRI showed recurrence of the original tumour plus 3 new brain metastases. Still no evidence of extracranial disease. So we started him on a BRAF inhibitor, and he had 4 lesions which we treated with radiosurgery, including this small one here right by the brainstem. So he remains well until February 2016, when he developed further brain metastasis here. So again, he had further radiosurgery, and we switched him to pembrolizumab. And in July 2016, he develops more brain disease, so including this large right frontal metastasis. So we treated him again. He continued with his pembrolizumab. And last scan in May 17, no evidence of disease at all. And I think this really illustrates the point that we have to remember that radiosurgery is a focal therapy, and this is being given in the context of a systemic disease. So it's really important that there's good systemic disease options, as well as being able to treat the brain focally. So he continues on his pembrolizumab. He remains very well. Now, what about multiple metastases? How many tumours can you treat? Japanese group did a retrospective study of nearly 1,200 patients, none of whom had whole brain radiotherapy, and found average survival for patients with 1 metastasis was nearly 14 months, 2 to 4 metastases, 10.8 months, and the same for 5 to 10. So the conclusions of this study was that SRS without whole brain radiotherapy in patients with 5 to 10 metastases is non-inferior to that in patients with 2 to 4. I think it's clear that the more you have, the more you're likely to develop, and I think you have to be very cautious about who you treat, but certainly we would treat patients with multiple metastases. Here's an example of a man we treated with 16, and this is a melanoma patient, all very small, and he, again, is doing well thus far. So where can we treat? And we can treat anywhere, essentially, with radiosurgery. So we're not restricted to non-eloquent areas, as the surgeons would be. Brainstem is a special consideration where we'd certainly have to attenuate the dose, and we've got to be very careful about what we do there, because obviously things, if they don't go well there, could be catastrophic. This is an example of a lady with breast cancer, actually not melanoma, who was initially treated in 2008, but then presented in March 2012 with dizziness, falls, and double vision. And she had hydrocephalus, so that's used to be called water on the brain, so blockage of flow of fluid around the brain. She had a shunt fitted, and this was her scan. So we treated her in April 2012 with radiosurgery. And following that treatment, not surprisingly, she required prolonged steroid use to control the edema. She was quite symptomatic. So by August 2012, we rescanned her, and this is a very typical post-treatment scan. So you see the black area in the centre where you've got dead necrotic tumour and this sort of ring around it. So we're happy at that stage. It's shrinking. It's the kind of appearance we'd expect. By March 13, it had regressed further, and by April 14, completely disappeared. And I saw her last week, actually, and she's had another scan, and she remains disease-free. So what about large metastases? So as I said earlier, one of the issues with large tumours is that they are more difficult to treat. You will create more symptoms. So now with the ICON, the use of the mask on the gamma knife, we can offer fractionated treatment of brain metastases. And these are the kind of fractionation schedules that we would be looking at. So by fractionation, I mean giving a little bit of a dose over a course rather than in one go. So 24 to 30 gray in 3 treatments is typical. What we do in Bristol is we treat with 10 gray, then give a 2-week gap, and then repeat that treatment, and then another 2-week gap and repeat that treatment. And what we find is that tumours shrink between treatments, which allows us to replan that treatment to a smaller dose, which significantly reduces the side effects. So we'd call this a sort of adaptive approach. So again, here's another example of a patient that we've treated, again, not with melanoma, I'm afraid. This is an esophageal carcinoma. So had 8 lots of palliative chemotherapy back in December 2014, then developed left-sided weakness in July 2016. MRI scan showed 2 brain metastases. There was a significant increase in volume on the planning scan compared to his diagnostic scan. So we looked at his scans initially, and too deep, not a good target for open surgery. But by the time he got to us, within a couple of weeks, the volume had increased significantly. So the volume of this tumour is about 16 cc. So it's quite big. It's at the upper end. It's got a lot of swelling, so that black rim around it is all the swelling in the brain. If you treat that in a single fraction, I guarantee he'll be unwell for a number of weeks, if not more. So we give him a lower dose, single fraction, comes back 2 weeks later, and we've got significant reduction in the volume. It's gone down to 6 cc's. So we replan him again, treat him again, comes back another 2 weeks after that, and it's down to 2.6. So we're getting rapid regression of that disease. And he sailed through that treatment without any problems at all, absolutely no side effects whatsoever. And I guess another benefit of fractionation is this. So on his 3rd fraction, we found another tumour, which was obvious in the cerebellum. His original first treatment scan, you can just about see it there, but it's very subtle, and I think it wouldn't be something you'd ordinarily pick up. So that was an extra benefit, if you like, of fractionating this treatment for him. And that's his 3-month follow-up scan. So you've got a very regressed tumour. There's a lot of scarring there, but no obvious active tumour. So what about the hazards of treatment? And of course, there are hazards. If you're treating high doses into the brain, there's inevitably a hazard. And I think the 2 hazards I would say for melanoma are radionecrosis and hemorrhage. So in terms of hemorrhage, first, there's no doubt that melanoma metastases are vascular. And again, along with renal cell cancer, they're the 2 ones that we worry about that are going to bleed. We've treated probably 200 melanoma patients over the years. I can think of 3 patients who have had a hemorrhage within 24, 48 hours of radiosurgery. So I think the risk is relatively low. It's unclear whether radiosurgery has caused those bleeds or whether these tumours would have bled anyway. And certainly we've got plenty of patients with brain metastases who've had bleeds and have never been anywhere near any radiation. Radionecrosis, again, is always a hazard for any treatment with radiosurgery. And what I mean by radionecrosis is necrosis of surrounding brain tissue. And that can mimic the side effects of the tumour. The question is that worse with immunotherapy? And there are certainly case reports to suggest that it may be in some cases. I think it's certainly a possibility. Looking at another case study here. So this is a lady with breast cancer, and this is a case of radiation necrosis that we had. So developed metastatic disease in 2009 in the lung, and then 2010 had a right cerebellar metastasis resected, then developed this left cerebellar metastasis in December 13. There's the treatment plan. 10th of March, this is her first follow-up scan. Everything's looking absolutely fine as we'd expect it. Tumour's regressing nicely. But in April, about a month after this, she developed severe headaches and vomiting, gets rescanned, so this is just 5 weeks later. And to all intents and purposes, that looks like recurrent disease. So she proceeded to surgery, had this tumour resected, and there was no active tumour in there at all. It was all just necrotic tissue. So clearly that is a risk. So in conclusion, I think it's very easy for us to decide what we can treat technically. It can be more difficult to decide who we should treat, but it's a generally safe and effective treatment for patients with limited brain metastases. But it's clear that selection of patients is absolutely key, and it's absolutely an important adjunct to systemic therapy in this setting. And I think I would reiterate once again that this is a focal therapy, and it has to go hand in hand with the systemic therapies that we now have available. And I think our outcomes for melanoma with radiosurgery are significantly better than where we were 5 years ago. Thank you.